Good morning. Good morning, Dan, Liz, welcome. We're glad to see you here. So I'm going to start with Dan. Dan, you've described Morgan Health as the private sector counterpart to CMMI. Can you expand upon that and also provide examples of some of your key initiatives?
Sure. First I have to say, this feels like I'm coming out of a cave that I've been in for 2 years, and all of you are here, so it's just thrilling to actually be here in person. So, Debra, it's great to see you. Liz, it's great to have you on the video, and for our audience, thank you for being here and for braving Boston. So, Morgan Health, in a nutshell, we are an organization that is focused on driving innovation into employer-sponsored healthcare. So we're focused on both the insurance aspect as well as prevention. So we really want to measure our progress by focused on really all the different facets of accountable care, improved outcomes, and mitigation of increases in costs for our employees, which is really a major focus and kind of how we're measuring success there on the cost side. And then third, achieving health equity goals. So those are the 3 sets of outcomes that we have going. We announced one transaction so far. So in order to accomplish that, we've got a great staff now, numbers 13, and really outstanding people that we've hired from all over, transactional background, health equity background, and a number of folks who are schooled in innovation, as Liz knows, and then because they came out of CMMI. And then in terms of the areas of focus, there is a fair amount of transactional focus. So we have $250 million from the JPMC balance sheet to invest in companies. And we announced our first transaction, which is a investment in a company called Vera Whole Health back in August. So we're working on that as well right now. So that's kind of who we are and what we're doing. And I'm not sure I answered your question, but maybe that's a good place to start.
No, I think it's great. Thank you very much. Liz, I'm going to turn to you now, please. You've described 3 areas of priority for CMMI. 1, advancing health equity. 2, driving accountable care by increasing the number of people in relationships that are accountable for their total cost of care. And 3, partnering to achieve goals and working with commercial payers and purchasers, including employers. Can you provide some more detail, a little bit more detail about those priorities?
Sure, thanks Debra, and thanks for the opportunity to highlight CMS strategy and our plans for the future. I really regret that I'm not there with you on stage. It looks like a pretty awesome event, and I have to admit to having major FOMO. But it's nice to see you virtually nonetheless. So we laid out the framework for this new strategy in a blog in Health Affairs in August. It was authored by CMS Administrator Chiquita Brooks-LaSure, who you heard from earlier this morning, and myself and the heads of Medicare and Medicaid, Dr. Meena Seshamani and Dan Tsai. And you laid out the 3 areas of focus that I would highlight as well. When we talk about advancing health equity, in our minds, this is one of the most important things we can focus on in the next 10 years and a really big priority for the Biden-Harris administration. It's a dog obligatory, sorry. As long as the mailman doesn't come. But for us, this means making equity a central consideration in every part of our work in terms of who participates in our models, to make sure we're reaching safety net and rural providers, collecting patient-level demographic data and standardized social needs data so we can evaluate the impact of our models, and also looking at new incentives and resources to make an appreciable difference in health disparities. In terms of driving accountable care, I think this is a central goal of our strategy. We want to increase the number of people in relationships with providers that are accountable for their patients' costs and improving their care. Our goal is to get 100% of Medicare beneficiaries in an accountable care relationship with a provider that's really overseeing their cost and care by 2030. This requires increasing beneficiary access to advanced primary care and ACO models, and also making sure that they're coordinating with or integrating with specialty providers. And then finally, you mentioned partner to achieve healthcare transformation, and that's probably most relevant for the discussion today. We're thinking about how to partner with commercial payers, purchasers, and state Medicaid agencies to make sure that we can expand the reach of our transformations. Medicare is an important catalyst for change. Couldn't do it without Medicare, but Medicare can't achieve transformation alone. So we want to work in tandem with commercial payers and purchasers in states, including organizations like Morgan Health. So that's the broad outlines, and I will say we are putting out more details of the strategy tomorrow. You heard it here first when we release a more detailed paper on a 1 o'clock webinar.
Great, thank you so much, Liz. That's an excellent segue to the next question. I'd like to ask both of you, the public-private dialogue is very important in advancing transformation. How do you view partnering? How do you envision collaboration? And where do you see real opportunity for partnership? And where are those areas that can really move the needle on driving accountable care and innovation? I'll ask both of you that, please.
Great. Well, for starters, I'd say that you can see the very close similarity between what Liz is carrying in her goals at CMMI and what we're carrying in our goals. We're both working with the same healthcare system. So, if in terms of our goals, driving accountable care is number one and is very core to the first investment that we made in Vera Whole Health. And what we're doing there is working with Vera and a really outstanding primary care provider, Central Ohio Primary Care, to bring a full risk capitation model to our employees in Ohio. And so in a lot of ways, I think it really mirrors where Liz is going with respect to the Medicare population. And then health equity is another great example. And we just actually last week concluded some discussions that are going to be a partnership between Morgan Health and Kaiser Permanente focused on health equity. So for the first time this year, our employees can opt into Kaiser in California. And we're going to be working very closely with Kaiser using their really outstanding data to be able to see what disparities exist, if they exist, and in our populations, and to work with them to close those disparities, to close the gaps. I think that, when you think about health disparities, a lot of people think about Medicaid, and to an extent they might be thinking about Medicare, but the literature shows that these disparities exist across populations, and Kaiser has been successful in reducing disparities as measured by real clinical measures in diabetes and cardiovascular disease. And we want to make sure that that is also being applied, monitored, and over time, that we can really track it over time in our population as well. And I think that, as employers, we have really an outstanding opportunity to hold the healthcare system accountable ultimately for elimination of disparities. And, in some ways, you asked the question, well, how do we work together? I think that I go in very realistic about the timelines in government. They can be very, very long. And, there are going to be times when we'll look at what CMMI is doing and say, wow, that's a great idea. We should go down that path. And I think accountable care is a nice example of that, where one of the reasons why we are succeeding so far is that the group that we are working with, Central Ohio Primary Care, already does fully accountable care and full risk care for the Medicare program. So that's kind of one example. Whereas in our partnership with Kaiser, we might get there first, and we might be, kind of the thing that pulls along and where we're pioneering some of those measures, and then we can give back ultimately to inform CMS's efforts as they bring those kinds of solutions to the market.
Great, thank you. Liz, what about you? How do you feel about partnerships? Where are you seeing the most opportunity for some collaboration?
Well, as you've said, Debra, partnerships are a critical component to advancing transformation, and we're trying to think about it a little bit differently. So in the past, we thought about multi-payer alignment at CMMI, come join our model, join our exact model with our specifications and our reporting and our timelines. And what we've heard from payers and states is that it's not an easy lift. Administrative burdens, timing, et cetera. So we're trying to think about things differently. And what does this new approach look like? And we're still building that plane as we're trying to fly it. But I think it's somewhere between broad concepts and principles and model specifications. So in the near term, we've received feedback about the importance of aligning on key APM, advanced payment measure design features to reduce administrative burdens. Can we have specific areas of potential alignment like clinical tools, outcome measures, innovative payment approaches to strengthening primary care? We also think about it through the Healthcare Payment Learning and Action Network, or the LAN. We're working through the LAN to launch a National Accountable Care Action Collaborative that will include recommendations on key APM design features. And then we're also thinking about geographies. So Dan talked about Ohio. I know they have some other geographies in mind. So we're thinking about where there could be a convergence of innovation, a critical mass of potential partners, a willing state health authority, and then other factors that might combine to make these efforts more successful. And then, you know, we've in the past been a convener, like how we work with the LAN, but we might also be a joiner. So it's possible that we can borrow from or build on other organization strategies. It's not an approach we've used in the past, but something we can explore for the future. Again, we're in the early stages of thinking about what this sort of alignment strategy looks like. But I welcome input on the strategy and this approach. And Dan, I know you have a lot of ideas for us, so we'll keep that dialogue going.
Well, speaking about ideas, and thank you, Liz, when we think about the dialogue, how about data sharing? What ideas and what thoughts do you have about that?
Look, data sharing is important. I think, you know, if I could maybe go back on the prior question, partnership is really important. And then, you know, in our context, we also don't want to be slowed down. So for us, partnership means working with the best healthcare organizations nationally, finding ways that mutual goals can be enhanced and to be pursuing them. I think that we also have to be careful that we don't slow ourselves down too much because we're impatient. Like, we want to actually make some progress. And so you know, our strategy is essentially to define the product, move the product through, help to really bring that to market more rapidly so that more employers can access these advanced payment models and others. Because there really aren't a lot of, there are a few, but there aren't a lot of organizations that are actually taking full risk and doing the kinds of things that are commonly being done in the Medicare program. You know, with respect to data sharing, I think that's a nice example. These data sharing agreements can take a really long time to work out. And if you're going to end up, you know, in 9 months of lawyer discussions and trying to, you know, get all the data sharing discussion together, it would be hard. You know, with that said, one of the advantages that we see of working with data-rich organizations like Kaiser is that they have the data systems already, and they can deploy those data systems, and we can receive reports without having to, you know, kind of go through too many hoops, and that ultimately is a way that we can have access to the data so that we really can be tracking and monitoring the kinds of outcomes, the kinds of clinical outcomes that we want to be making progress on.
How about you, Liz? What are your thoughts on data sharing? And I think, Dan, you raised a really good point about the timeline for some of these initiatives. So Liz, I'd love your thoughts on that as well.
Yeah, I think we're thinking about data sharing along two lines. First of all, the Innovation Center hasn't been sharing data from our models for research purposes. So most of the Medicare data, you can access it through various channels, but you couldn't access it for any of our models or our model participants. So we're looking at making more of that data available. I think that's on sort of a broader scale. And then we're also, as part of our strategy, really thinking about how we can make sure that we have actionable data available to model participants at the time when they need it to actually change and influence care behavior and care delivery. And that's, I think, you know, if you get data 6 months, 12 months later, it's, you know, by that time it's not very, it's not as impactful. So we're looking at trying to give more real-time data and exploring means to do that. But then, you know, what do you do about those providers that aren't participating in the models? Could we even go one step further that data are available for providers that want to participate in alternative payment models, but not necessarily through CMMI? So that's sort of longer down the line, but a lot of that work is ongoing.
I think it's also Liz, to commend your efforts in making the government data more available. I would say that a lot of the companies that are here at HLTH that are succeeding in terms of analytics are doing so because of the Qualified Entity Program, because those data are so valuable and have been so helpful in developing clinical algorithms. And so, that's something where I think the more in government you can push to make the data available, that's a place where kind of public-private partnership can really benefit.
Thanks, we're trying. We hope to get there as soon as possible.
So if we think about some near-term opportunities, are there certain areas or sectors that you would start to think about that might be a near-term opportunity versus a longer-term opportunity in terms of partnerships?
Well, like I said, we're looking at certain geographies, in conversations with purchasers, talking to Dan, talking to some of the large employers about how we might at least think about centering our models in where they might have be able to compound the impact where others are also doing similar work. We're in conversations like, could we come up with quality metrics that match what others are doing on the ground? So providers, to make it easier for providers to participate. I think some of those, we're relaunching the LAN and thinking about different goals. And I think there's a lot of input that comes in from a lot of different stakeholders. And so in that dialogue about how to define what could work, like I said, we're at early stages of thinking through this, but I think it's a really important conversation. And it's different from the way that we've worked in the past.
Yeah, maybe to elaborate on that a little
Sure.
bit, I think that when you think about accountable care, it's so dependent on providers being fully aligned. And if Medicare has one set of measures and we have a completely different set of measures, it can be difficult. So to the extent that we can harmonize or standardize, it will really benefit everyone. And the fact is that in terms of accountable care, Medicare is ahead of the commercial sector, is ahead of employers. So we are learning from that. As I mentioned before, Central Ohio Primary Care being so involved in Medicare contracting is an advantage, but it doesn't get us all the way there. There are a lot more deliveries in our population than in the Medicare population. There's a lot more of certain types of conditions, and the fact is that it's going to look different when we go to market. But to the extent that we can coordinate in geographies with the models that exist, we would really very much like to do that, and that's one of the reasons why we're in talking with Liz and her colleagues. I think another nice example is on the measures where if you think about health disparities, I mean, one question you could ask is, well, what are you really doing? It's everyone's out there talking about disparities, and we would really like to focus on known clinical measures, A1C, A1Cs, cholesterol levels, whether people are getting routine cancer screenings, and to look at these routine measures, which are already very well accepted, and then to compare by race, ethnicity, to make sure that any observed disparities are closed. So it's a simple approach. It's one that kind of gets us, it's not as clinical as we would like, frankly, because there are a lot of other things that we would really like to measure, but you have to start somewhere, and starting practically, I think, is really how we're thinking about it, and that's the kind of thing that we would like to synchronize with CMMI.
That's great. It leads into another question that I had was for both of you, as you look out 18 to 24 months, how do you define and how do you importantly measure success? I'll throw that out to both of you.
You want to take it first, Dan, or you want me to answer?
It's up to you. Go ahead.
All right. Well, this is something actually we've been giving a lot of thought about. And that's because in the last 10 years, we've launched about 50 alternative payment models, but only 6 have generated statistically significant net savings, and only 4 have met the standards to be expanded in duration and scope, as the statute outlines. And that's home health value-based purchasing, Pioneer ACOs, a non-emergent ambulance service model, and then the Medicare Diabetes Prevention Program. It's not a bad record by any stretch, but I feel like we can do better and we can do more. So we're really looking at launching fewer models that impact more people, and are more lasting and scalable. And I think that's where this multi-payer alignment comes in. So in determining success, like I said, we've been giving this a lot of thought, and we are thinking that it's not just meeting this standards for certification, because the notion of certification, which is laid out in the statute, is really narrow. It's a very high bar. It means that there's a 95% confidence interval that a model will generate savings on a net basis. But it doesn't say anything about whether it's had a bigger impact or help, really transform the health system. So we're trying to broaden our definition and think about success in terms of, was it broadly embraced by model participants? Did it improve care delivery? Can it be easily replicated even by non-model participants? What's the likelihood that other payers could adopt this model? Does it reduce health disparities? It's sort of another dimension to how we think about success and possible outcomes. And, you can meet the standards for certification, but again, not be transformative. So conversely, I think if you look at some of our models and some of the models that model participants speak very highly of, like the next generation ACOs, where we really thought we were transforming care delivery, but we didn't meet the standards for certification. And maybe in that case, the outcome isn't expansion, but a recommendation to Congress or incorporation into an existing aspect of Medicare. So really trying to look at things through a new lens.
Great, thank you. Dan, from the private side, how do you define and measure success?
So we are blessed with a less regulatory environment, and we're really thinking about things from the patient's perspective. And as I kind of mentioned in the setup, our goal is to improve outcomes, reduce patient out-of-pocket costs, and eliminate health disparities. And so really for us, taking a patient's lens on it, we will get as clinical as we possibly can with the projects that we are focused on. So in the context of the work that we're doing with Vera, we will look at specific clinical outcomes measures. Again, whether it's the standard boring measures, but that's where we are going to start. And it's going to be diabetes and cardiovascular disease and cancer screenings and the like. Then, with respect to the disparities, we'll be looking at those measures to see how things level out. And we want to see them be equal. And that is kind of where we will measure our success, is in the closure of any gaps that we observe. And look, I think that in the broader context, look, we're an investor, and we are investing capital, so we want to see the companies that we invest in succeed. So that's kind of another set of metrics that we will be carrying. But we're a strategic investor, and ultimately what we care about more than the return on the capital that we are deploying is the achievement of these objectives that we laid out, again, outcomes, quality, cost, and health equity.
So thank you. When you talked about kind of the more basic metrics, again, going out maybe towards the 24 months, do you have kind of a second wave that get a little bit more aspirational in terms of those measures?
Sure. I mean, look, I think we all have to be realistic and somewhat humble that change has not come as rapidly as anyone would have liked. And so in terms of setting the expectations, I do think it is really important to start very simple with metrics that are familiar to providers and familiar to health systems so that we can progress here. So if 3 years from now, when we start to understand, and I think, again, this is a place where we learn a lot from what has happened at CMMI, it takes a long time to evaluate these projects, and you learn as you go. So if some number of years from now we're doing really well on the metrics that we're using today, we absolutely would like to expand to more clinical metrics and to make sure that we're progressing health in really all of its aspects.
Liz, does that align with your thoughts as well in terms of that timeline, a little bit more aspirational types of objectives?
I think Dan laid it out really well. I think we're aligned in a lot of ways, and yes, he can do things a little quicker than we can sometimes, given our clearance and regulatory process. But we're right there with you, and I think interested in being that partner.
Great. Well, this has been terrific. We're running out of time, but really very interesting, and I'm sure for a lot of our audience members would be interested in how they can potentially partner and collaborate with both of you. So I thank you very much for a very interesting conversation.
Thank you.
Thank you.
Thanks, Debra.
Thanks, everyone.
Thanks, Dan.
Thanks, Liz.
Hi, Liz.
Bye.
Thank you.